done quite a lot of work in the Innovation Agency to theme the information that we hold. So we're aware of, we have on our radar over 200 innovations. That's quite a lot of information for anyone, me included, to be able to hold in our head. So we've tagged and categorized all these innovations into one of 8 categories. And this category, what we're talking about today in terms of greater resource and productivity in primary care, is one of those categories. So hopefully it's going to be a topic that's going to be of interest to everyone on the call today. Really critical topic for the NHS. We know that the primary care deals with over 90% of first contacts, and with only 11% of the total spend of the NHS. So really ensuring productivity for these small businesses is really important. So on the line today, we've got Sanjeev, who's a GP, who's developed a digital product for primary care. It's an e-consultation service called GP Connect. After Sanjeev, we'll have Jane Stokes talking, who's a representative of MymHealth. And then our last speaker, last but definitely not least, is Tom Bell, who's a University of Central Lancs project manager for digital health. So Sanjeev, can I pass over to you to go first?
Thank you very much. Hi, everyone. I'm a GP and developed a product that I felt would benefit my patients. And we're all probably aware that there's a lots of e-consultation sort of services available, either run by private companies and also being run by organizations with the NHS. Providing, to patients. I've created something that I think is a bit different, and I'll go through my slides, which is very brief. I explain to you the reason why we developed it in this way. So just to kick off, what I've got here is the slide shots of the app that patients download. It's free to download on Android and iOS. And essentially, the service is designed to work to prevent, to try and allow patients to connect to GPs remotely without the need to having to have a face-to-face consultation and attending GP surgery. So if a patient wants to connect with a GP, they download the app. They go through a process of accepting terms and conditions, and part of that is also to signpost patients to conditions that are not suitable to be used via an e-consultation service. So we've listed a lot of red flag conditions and symptoms that if they do have any doubt, they're advised to contact their GP. We've implemented for our first pilot to launch a simple process of patients selecting a date that they would like a consultation. So they go on the menu and they select the date. They then presented with a list of appointments that are available for that particular date. And the appointments are with a named clinician. So you could have, for example, in my surgery, if I've got 2 or 3 doctors or even an advanced nurse practitioner, they can book an appointment with the person they would like. So they do see the name of the clinician on the app that pops up, and they select an appointment. They go through a list of appointments, select a time, and then they're presented with the screen where they actually have to select the subject matter they want to talk about. And this is one of the ways to try and reduce inappropriate use of the service by booking for the wrong subject. So we've listed a list of message subjects they can select from. Things that are common in primary care, things that are suitable to be used via an e-consultation service, example, allergies, back problems, and so on. And then they, on the I tab, which you'll see on there, if they select on that, they are then presented to a page where it takes them through the symptoms related to the subject they've selected. So if it's about back pain, it'll give them some information about back pain, and also can direct them to a website. For now, we've chosen NHS Choices website, where they can see more information about back pain and problems. So it's appropriate signposting. The patient then enters the details of their symptoms on the message box. They then select, once they've done that, they can enter a preferred contact number. That can be any number they choose. If they're at work, they can select a work number. And then they're given an option as well to submit an image if it's appropriate. So assuming they've selected something to do with a skin condition, they could do that. Or they could submit a video. They're given up to 90 seconds to submit a video. And they can basically send a video message to their GP about their symptoms and conditions without having to fill in a lot of details in the message box. And if they're happy with that video or image, they can confirm it, or they can given an option to retake it or cancel it if they decide they don't want to upload a video. Once they've done that, they then review the appointment details they have. And they confirm their appointment, and they will get a confirmation to say that their appointment has been successful, booked for the date and time they've chosen. At the end of that, they also ask to provide feedback if they wish. So we've created a feedback on the app about the service and how to rate it. Because we're piloting it at my surgery, I thought it's useful to get patients' perspective on how they find the service. And they can remain anonymous if they so wish, and then they send the feedback about the service they've used. The GP on the other end connects to before I go to that step, once the patient's booked their appointment, so assuming they booked it a week in advance, they have the option of uploading a further message with a video or an image to update the clinician prior to that consultation about their symptoms. So, for example, if their conditions change in any way, they can send a further a message or a video about their condition. So when the GP connects with them at that date and time, he will have more information as to how the patient's been doing. So it gives the opportunity for a patient to provide more information prior to his or her appointment. And once they've done that, the GP then connects to their platform. What I've designed here is allowing the clinician access to all the appointments that have been booked. But because I feel as a GP, I'm under a lot of pressure as well and time, and I find live video streaming does not actually save a lot of time for clinicians. The clinician has the opportunity to preview the information that patients have submitted and sort of save a response that he or she wants to send back to the patient. And the clinician can connect to the patient in two ways, either by sending a message to the patient or ringing the patient on the preferred number they've selected and discussing the symptoms or the problem that they're presented with, and giving the clinician. I mean, I feel connecting with the patient this way gives the opportunity to provide a better and safer way of providing a telephone triage to patients, because we don't do live streaming on our platform. My intention is, as I said, to pilot the service. We plan to launch the service next week and run it up until the end of March, and then get feedback. And that's essentially my GP Connect platform. So if there's any questions, I'm happy to answer them and maybe give you more information if you need to know more about it.
Digesting what you've shared and thinking about some questions.
Yeah.
I've got a couple of questions, if I can take chair's prerogative and fire through at you, if that's okay.
Yeah.
I'm curious about when people book their appointments, does that write through onto your clinical system, onto your booking system?
Yes, so the part the part I've not shown you, it is linked to EMIS. So on our the front end platform is actually web-based like EMIS is. So clinicians will log on and access all the appointments. Patients also have the option to cancel appointments as well. So once they've booked an appointment, they can cancel that, and the appointment will be removed. the platform has additional features as well to make certain times available or unavailable. So if a GP is deciding I'm not going to be working this time, he can block off his or her times as well. They are more inbuilt user functionality in terms of how the platform works, but I've kept it very basic for this presentation. But yes, so when a patient books an appointment and once the clinician has reviewed the information, sent a reply back to the patient, it's filed away, that gets uploaded onto the EMIS patient record as a consultation.
Fab. Really helpful. And another question from me, if you don't mind.
Yes.
I'm interested in the last point that you made around you being able to review those appointments that have been booked and reaching out
Correct.
to the individual
Correct.
to ask them, maybe call them. Do you ever see a view where you might look at them and go, oh, do you know what? Actually, you don't need to see me. You might need to see a physio, or and that you divert people to the services.
So the idea behind this is there's in terms of a GP, if I had to review, say if I reviewed the information prior to seeing the patient a week, I could message the patient. There's nothing stopping me from connecting with the patient at any time, because when I send a message to the patient gets the full details of my consultation and whatever action plan I put in place prior to that date. So there's nothing stopping me as a clinician engaging with the patient sooner and not having to wait for that appointment time the patient selected, because the patient will get the message once I've sent it outlining what my plan is. The other option is as well, what the next step that I'm looking to do is, as GPs, we've created GPs are now forced to look at providing different skill sets in their clinical practice. So I have 2 advanced nurse practitioners, for example. I have a clinical pharmacist. We are planning to link the message subjects. So assuming if a patient needed a review on their medication, for example, that would be filtered only to the pharmacist. So they will only see appointments relevant for the pharmacist to book that appointment. If we had a particular aspect that we say that the advanced practitioner could deal with, so the sort of the less complex problems, they could be filtered to that clinician. That is the next step that we will be implementing. So when you select a subject, for example, you've got a doctor that is maybe good at dealing with skin conditions in the practice, that could be filtered to that particular GP to deal with that patient. You've got somebody that's very good at dealing with mental health, for example, or whatever problem you feel that's relevant to the skill set within your practice, you can actually divert those appointments to the right person. But that's something, as I said, we haven't implemented as yet. We would very easily implement that if the platform was, say, being used at another practice that needed that functionality. We could provide that moving forward.
Fab. That's really interesting, Sanjeev. Thank you for sharing all of that information. I can't see any questions in the chat box. Everyone is obviously listening intently, but being quite shy. And Sanjeev, I know you've got another meeting to get off to. So I wonder if we leave it there, and I'm sure people will be able to reach out to us or you. You've kindly offered to share your contact details if people want to know some more information.
Thank you very much.
Great. Thank you, Sanjeev.
Thank you. Bye now.
Bye. So I'm now going to pass over to Jane Stokes, who's from MyMhealth. Hi, Jane.
Welcome to everybody who's dialing in. So what I want to talk to you about today is about MyMhealth and the long-term condition platform. So I am Jane Stokes, physiotherapy lead for MyMhealth and project manager for the north of England. MyMhealth are a company who develop apps for long-term condition management. So the first app that we developed was back in 2011, and that was MyCOPD, which was a website which just enabled patients to access education and some basic exercises for their MyCOPD management. That was then taken forward through some National Innovation Accelerator Programme funding and some SBRI funding. So there was over £2 million of funding went into further developing the apps, developing the evidence base behind it, and further developing the user interface. And we were then one of the first softwares on the Innovation Technology Tariff in 2017. That got us working with over 50% of CCGs across NHS England rolling out MyCOPD. On the back of that, we then as a company looked at, well, what we're aiming to do here is empower patients to better self-manage their long-term condition. To do that, you can't do it solely for their COPD if they've got multiple comorbidities. And what we now know is that over a quarter of patients with long-term conditions have multiple comorbidities. So we've invested in further development of the apps into now a long-term condition platform, which has patient self-management apps for asthma, diabetes, heart disease, and COPD. I think the unique selling point of all of these apps is the fact that it's a familiar user interface for the patient, but there's a single login. So if you provide access for your patient to MyHeart and MyCOPD, certain data that the patient enters will auto-populate between the apps in terms of patient details and certain metrics that they're entering in. But also they don't have to then log into their MyCOPD. They click on the Switch App button at the bottom of the screen, and then that will take them to their MyCOPD or MyHeart, whichever one they're not in at that time. So it allows them to seamlessly travel between the different disease areas from a familiar user interface in one platform. In terms of the development of the apps, further development's ongoing. We're very invested in the research behind the apps and the research behind the long-term condition management for each of these disease areas as well. But we've been working on developing what we call a FHIR, which is an API enabling computers to speak to computers, basically. But what we've done is built an API which is going to achieve access to the NHS spine, which is now open to us, to enable us to pull and push data. So it's going to make it more interoperable with the current electronic patient records. So in terms of using it in primary care, secondary care, community services, it's going to have increased interoperability and functionality. It already synchronizes with a number of different wearable devices through Bluetooth. So we've also got some point of care testing devices coming on board as well, which will be interfacing with the applications. And other collaborations we're looking towards would be e-scripts and online doctors. So these are the further developments for the future. So as it stands, we've got the 4 different disease areas, but one of the exciting developments for this year has been the release of MyTeleHealth, which is the next logical progression. The apps themselves are designed to empower patients to be better able to self-manage their long-term conditions, and they are patient-owned apps and patient-managed apps. However, the MyTeleHealth is an extra step of hand-holding to support a patient through a time of crisis, whether it be admission avoidance or early supported discharge, with more intensive support and ability to monitor remotely through Bluetooth devices, two-way messaging. I'll talk about that in a little bit more detail. But underpinning the telehealth at all points is the self-management app. So when you're then discharging patients off telehealth, you're still discharging them to the familiar support mechanism of their self-management platform. So what we do for patients is we provide patient empowerment through a patient-centered evidence-based platform. It's about self-management and how they best manage their long-term condition with confidence. One of the key themes that we get when we ask patients for feedback is how it actually improves their feeling of control of their long-term condition. And also we enable patients to understand how to best achieve outcomes to optimize their long-term condition. How we do this, each of the apps provides education which is tailored to the patient's condition. So if they've got angina, they'll see an education program which is appropriate for angina. If they've got heart failure, they see an education program which is appropriate for heart failure. It comes in written format or video format. Each of the videos are 3 to 5 minutes long, all shot in-house. All of the sequential education course they can go through. But the key thing is it's at a time and place to soothe the patient and unlimited viewing. There's inhaler videos as well for the MyCOPD and MyAsthma applications. These inhaler videos are all once again shot in-house. They're put before the National Inhaler Group, and they've been shown to improve inhaler technique by 98% in a cohort of patients where 90% of patients had at least one critical inhaler error in their inhaler technique. There's medication advice and the ability to record concordance. There's also rehabilitation. So in MyCOPD, we've got a 6-week pulmonary rehab program. In MyHeart, we've got an 8-week cardiac rehab program. And in MyDiabetes, we've got a DM Fit program. Patients can monitor their symptoms. They can look at reports over time to see how well they've been managing their symptoms. They can also look at their clinical management plan, which once again is tailored to the patient. It auto-populates with the medication that they're on, and it can be further tailored from the clinical perspective to reflect localized pathways. The user interface is tailored to the patient. So as I said previously, if the patient has heart failure, they will see symptom score tiles on their app. If they don't have heart failure, those tiles won't appear. If they are a smoker, they'll see a smoking cessation tile. If they're not, it won't appear. There's ability to set targets from the clinical user interface in collaboration with the patient, and the patient can review the targets and see how they're achieving those over time as well. So initially, the products were purely based as a self-management platform for patients, but then clinicians came to us and said, well, actually, I wouldn't mind seeing that information. I think it would help me to remotely manage my patient population. So we said, well, absolutely, we'll see what we can do from that. So part of the terms and conditions when the patients first log on to the app, one of the terms and conditions is whether they want to share their information with the clinical team who are involved in their healthcare management. If they choose to share their information, then they are pulled into a clinical overview, and the clinicians can use this to manage their patients remotely at scale, improving access to healthcare and reducing inequality in a resource-efficient vehicle. How it actually looks, I mean, it looks a bit small on the screen here, but you pull your patients into a caseload. You can then risk stratify them based on, for example, in MyCOPD CAT score, severity score. You can see if they've engaged in pulmonary rehab. You can see if they've done their education course. So it enables you to monitor patients remotely. It also will be suitable to support an annual review. So for COPD, you could send a message to patients before their annual review and say, please update your MyCOPD. They would update their CAT score, exacerbation history, concordance of medication. So you'd be able to see that information when they're coming in for annual review. It helps to rationalise resources, because if you can put up your caseload and see that certain patients are managing their condition well, they're reporting that they're good, they're engaging with the app, but then other patients aren't, you can start to attribute your resources towards those patients that aren't engaging or aren't as well. It has the facility for one-way messaging, and it's one way for a reason, because this is about patient empowerment. So we don't want the patients then waiting for you to check the app to respond to a message that they've sent. This is purely about the clinicians being able to send a message to the patient. For example, to all my COPD patients, I might say, the flu vaccination is now available from your local healthcare provider. Please contact your GP to make your next appointment, or your pharmacy to make your next appointment. So you've pushed the ball back to the patient to take the next step. MyTeleHealth, as I mentioned recently, it's an increased level of support, and it can be used to avoid admission or support early discharge. So we've got Bluetooth devices that would be sent out to the patient from the team and set up with the patient. They would also be set up with their long-term condition platform if they aren't already on it, and the user interface for MyTeleHealth. Now, it doesn't need any more technology. It can be used through any device that the patient already owns that interfaces with the internet. So smartphones, TVs, laptops, tablets, Xboxes. And it's not just the patient. So we've got a number of elderly patients that will attend all appointments with a relative who is already supporting them in their healthcare. So if the patient consents and their relative wants to support the patient, there's no reason why you couldn't give the license to them. So they've still got access to all the education, all the resources to work through together. So when they're on MyTeleHealth, they could be doing their daily readings. That would auto-populate into the app. The clinician's able to monitor that from their user interface, and also direct the patient to their self-management app and say, okay, so I've noticed that your sputum is starting to change colour. Make sure you watch the sputum clearance advice video in your MyCOPD. And then when you're starting to discharge the patient from telehealth, you're just discharging them onto the familiar platform. So it's a really good opportunity for seamless care through crisis periods. In terms of the evidence, we've got two main RCTs, and we're investing in further research going forward, which is ongoing. So the first one was the Trooper study, which was published in 2017 in the BMJ. So this, we actually pulled everything out of MyCOPD, but left pulmonary rehab in there, and patients were either assigned into traditional face-to-face pulmonary rehab or given MyCOPD. What we found from the study is that we were able to deliver parity of care with face-to-face for stable COPD patients. The second study was Rescue COPD-1. So this has just been presented at the ERS and is awaiting publication in Thorax. So we did the converse of Trooper study, and we removed pulmonary rehab from MyCOPD, but left everything else in there. So all the inhaler videos, all the education. This was given to patients post-exacerbation in hospital. So either they were given traditional discharge in terms of showing how to use their inhaler face-to-face, provided with relief of it and discharged home, or they were given MyCOPD. What we found that was the patients given MyCOPD had a significant improvement in their CAT score. We actually saw a double rate to recovery of baseline CAT score in the treatment group, significant reduction in exacerbations, and in significantly improved inhaler technique. So in this study, it corrected inhaler technique by 95%. In terms of the governance and approval, so we are the only NHS approved app. If you go onto the NHS app library, we operate under strict clinical governance framework SKY 0129. We are IGT level 2 compliant and classed as a class 1 medical device under the MHRA. We assist with the delivery of best evidence-based medicine, and we've just recently achieved Kismet approval as well. What we do for patients, as I said, the key theme that we get from all the feedback is the regaining of control. Patients quite often repeated they felt they knew nothing, their family knew nothing, but the app has improved that and helped them regain control of their life. Through empowerment strategies over the last 20 years, we've tried to empower patients by imparting knowledge, but we've almost oversaturated every contact point now by throwing too much information at patients, and it's not absorbed. They take away maybe 2 or 3 bits of information and the rest is lost, and it's not always taken away correctly. This gives you the ability to impart that knowledge at a time and place to suit the patient with unlimited viewing of the education and the inhaler videos. Examples how it's been used in practice. So in Bradford, they're launching My Diabetes as part of their level 2 management. So they're going to be going down from 3 face-to-face reviews a year to 1 face-to-face review a year and 2 digital reviews. Knowsley CCG are launching the whole platform approach with asthma, diabetes, cardiovascular disease and COPD offered to all patients through the app as a digital underpinning to current service delivery. In West Lothian, they've had great success with MyCOPD, and this has been more about providing access to services in a geographically remote area, where you've got the challenges of getting people centralised to rehabilitation sessions, clinics, etc. And they've been doing some really good evaluation pieces, which I can provide to people if they'd like more information on those. In Southend, they've increased the throughput from pulmonary rehab by 100% by offering a digital offering in MyCOPD. And Guy's and St Thomas's are about to get going with MyHeart to support their delivery of cardiac rehabilitation as well. I've got clinicians who are using it to support clinical delivery. So there was an evaluation in Newcastle which found that 70% of clinicians teaching inhaler technique had at least 1 error in their own technique. So I've now got clinicians, I'm saying, right, remove that room for error, use the app, even if you're not giving a license, use the app, the test patient that we normally create with each CCG that sets up. Use that app to demonstrate the inhaler technique to the patient. If you are then setting the patient up with a license, you've introduced the user interface and it's an easier conversation. If the patient's already on, they're seeing you using it, it drives up their engagement, their familiarity with the app. So it reduces inconsistencies of care. I've got other rehab services as well that are using it to support their education sessions. So for more information, please visit our website, which is mymhealth.com, and thank you for listening today.
Jane, that's fab. Thank you very much. A lot of information there. So we've got a question in the chat box from Rebecca. So she's asked whether you have a fluid management section within the app. She's developing a product to track hydration and fluid input in primary and secondary care.
Yeah, we do. So if a patient is diagnosed with heart failure, there's the ability to monitor and track fluid. It's patient reported at the moment. So they basically record what fluid intake has been for the day. They've got targets set so they can see how they're performing against their target fluid intake.
Fab. So it sounds like Rebecca's asked she'd be interested to speak further. So perhaps we could put you in touch offline. Yeah,
please do. Yeah.
Brilliant. Brilliant. And in terms of how this works in primary care, I wonder if you could touch a little bit on, is it the specialist nurses who generally work with patients in terms of using these apps? Is that how you're seeing it have success?
So I've got a number of nurse practitioners and practice nurses who are using it, and also HCAs in primary care who are supporting patients to get going with the apps. but I've also got GP leads who are very engaged with digital, who've been very keen to get going with this. So they introduce the concept to the patient. They don't necessarily get the patient up and running. They use an HCA to support that. But the practice nurses that I've been working with, they actually introduce the concept to the patient, use it to demonstrate inhaler technique, and then register the patient live.
Fab. I think that's really helpful. Thanks, Jane. I really that was really interesting, and I will pick up with colleagues about how we put you and Rebecca in touch after this.
Thank you.
Thank you. So, Tom, hi, Tom from the University of Central Lancashire. Can I pass over to you? I think we're just getting your slides set up.
Indeed, thank you very much. Yes, I'm following some great stuff there, aren't I? There's some really quite exciting things happening. And I like the introduction, by the way, you know, the expectation of 3 fantastic presentations, so no pressure there at all. So I've got 10 slides. I shall set the 10-minute timer on my telephone to kick off now. And the aim of this presentation from me is to make connections, which I think, interestingly, I've already made with the 2 previous speakers, so that's great. There's some really good networking going to happen there, I'm sure. And also to share what we're doing with people who might want to contribute to this project or just want to be kept abreast of it. And so thank you to the HSN for the opportunity to present this. Right, okay. So who am I? So I am a project manager with University of Central Lancs. I am based at the University of Central Lancs' campus in West Cumbria. I have an interest in rural healthcare systems, an interest in technology and data in driving both quality, quantity and equality. That's not both, is it? That's 3. Quality, quantity and equality of care. I'm a chartered marketer. I'm a former NHS manager, so I share the pain. Former small business advisor, and I publish a cheery weekly online paper called Let's Talk Suicide for personal reasons. Now, I joined the NHS in Cumbria in 2012, and I remember asking my director for access to the performance dashboard. Some of you will be laughing out there. It's a good thing that you're muted. When I asked for access to performance dashboards, thinking that this would all be set up ready for anyone to look at, you'd think I'd sworn at him and spoken in Swahili all at the same time. And this was at the point when I realised that the NHS was technologically challenged, though at that point I had no idea just how much. If I was going to be on Mastermind, which I never will be, my speciality would be using the obvious to make a difference to public sector services. And the screenshot that you can see there in front of you is from an initiative in 2012 where, in partnership with a number of GP practices and some third sector providers, myself and some colleagues designed and implemented a directory of community and mental health services for primary care and other referrers. This is people like third sector, probation, adult social care, police, etc. And the rubber hit the road for this project when I let slip that as an information asset we would need a little funding to maintain it, as it couldn't just be placed online and left to its own devices. That was to no avail, and those working in the NHS are probably not surprised by that. There's a sense, I think, sometimes that, don't get me wrong, I think there's some fabulous stuff going on in the NHS, but having read the latest strategy that's just come out, I think a vision or strategy document from Matt Hancock's department, there's a real emphasis there on getting the basics right, isn't there? And things like directives of services, making information visible to people, those kinds of things. I think we've still got an opportunity to do some of that. The patient-facing digital offer from primary care, what does good look like? This was of interest because if I go right back to the start of this, I think one of the presenters, Jennifer, I think it might have been yourself, you talked about 90% of demand coming through primary care. You know, and we know that, don't we, that primary care is the very, very large top of that funnel, which takes healthcare need into it and then, you know, brokers it off to different places. And if you look at the current patient-facing digital offer from primary care, hence my excitement about seeing the previous 2 presentations, you'll see that it is really, really quite inconsistent. Many people don't know their practice has a website. Now, we know that from some research that we did in Cumbria. Of those that do, few think it is good. We also know that from the same research that we did in Cumbria, where I think less than 1 in 5 people who did know that their GP practice had a website thought it was unambiguously good. If you talk as well to practices about their websites, they don't know how those websites perform. In fact, that concept of how my website is performing is really quite alien, and that's not a criticism, that is purely an observation. If you ask, for example, as we have done, we've had groups of GP practice managers coming together, and we said, hey folks, right, where would you go to look at the statistics for your website? Who understands the Google Analytics? Do you know what people are looking for on your website? Do you know where they enter, where they leave, how much time they spend, etc., etc.? All those things that, if you're running a small business and running a website to help you manage demand, you would strive to get your head round. And again, I can't stress enough, that is not criticism, it's purely an observation. I think a lot of practices have got a website because they were told they should get a website, and now they have it, there's a sense of, right, well, what, not really understanding what it could potentially do for them. What we did also was we'd done a fairly comprehensive audit, if you like, of all the GP websites in Cumbria. Our focus, of course, is that Cumbrian patch. And that was really quite revealing and quite interesting in terms of seeing how inconsistent sites were, that different providers had different views of what should be on there. And there is really no version at the moment of what good looks like. There's also no such thing as a typical GP practice, and there's no such thing as a typical GP practice manager. Again, not criticism, purely observation. But there's a sense of what you've got is this top of the funnel where 90% of the demand is coming in, and that appears to be the most fragmented part and the least developed digitally in terms of that patient-facing digital offer. I think there's a real great opportunity here to develop a project looking at a version of what good looks like for primary care websites, which would help practices collaborate in quite a soft way, a more culturally acceptable way of getting practices to come together. In terms of primary care being the top of that demand funnel, we've talked a bit about that. We understand the drivers for this, and the needs of the system are that the system needs to optimise the clinical capacity that it has. That is a finite resource, and it needs to get the most out of it. Really interesting that when you talk to practices, talk to GPs, again, I haven't seen an evidence base for this, but anecdotally, what they will say to you is, depending on who you talk to, that anywhere between 2 out of 10 or 5 out of 10, so that's 20 and 50% of appointments that come through the GP are unnecessary, i.e. they could have been dealt with in different ways. So I think there's something there, isn't there, that we're saying the system needs to optimise the use of the clinical capacity it has, and its users need easy access to relevant services, expertise and information. That phrase there that I've used, technology is the ultimate broker, we're all familiar, aren't we, or we may be familiar with when we used to go and shop for insurance. And I remember we had an insurance broker in Penrith there, and the clue was in the title, it was an insurance broker, and you would walk in, you take your documents and take your requirements, and that broker would try and find you the best deal from what they knew was available. And what you were working more there with was a limited pool of knowledge, i.e. that the broker only knew what they knew. They tried to keep themselves in the loop. Now, of course, we're all using, aren't we, Compare the Market or Money Supermarket or all those other things, and we use eBay to find services and products that we might never have known about. Technology really is the ultimate broker in terms of need versus demand to meet that need, needs, wants, etc. And it feels like if we can get this patient-facing digital offer from primary care right, there's a really great opportunity there to create a vision and a version of what good looks like. So what we have done is we have worked with various people from within NHS England, and we've unearthed that opportunity, if you like. So the research that we've done in Cumbria, which is originally part of the construction of the digital roadmaps, and the surveys that we've done, the meetings with patient participation groups, the meeting with practice managers, have given us an evidence base, which we then escalated to a guy called Dr. Masood Nazir, and some of you will know who that is, who works within NHS England as the primary care lead for digital transformation. And NHS England have now said that they would like to work with us. They like the space that we're looking at. They like the idea that if we could develop a version of what good looks like for that primary care patient-facing digital offer, they feel that would work really well for them. So we're now engaging with health and care stakeholders at all levels in Cumbria. We have a project that's running. NHS England have very kindly put a small amount of money into a project which will run through to the end of March next year. And the idea is that we will produce 2 things for them. So the 2 things that we will produce for NHS England are an online example of what a good primary care website could look like, and documentation and research that will go underneath that to say, look, the reason it looks like that is this. In other words, we provide the evidence that underpins that rationale. And I think that's what NHS England are really interested in. I think it's quite an exciting project. I think anyone like me, a ruralite who lives in a place like Cumbria, and even not a ruralite who wants access to better services, better information from primary care, this feels like a really good opportunity. So we're engaging with multiple stakeholders. This is, as I say, primary care there. We've got patient participation groups across North Cumbria, carer bodies, health watch, third sector providers, and obviously speaking with the system providers who exist at the moment. So this is your EMIS, Egton, iPlato, etc. And as I say, the two previous presenters I think will be great contacts for us to keep up to speed with. So in summary, very briefly, we think this is quite a simple project. That is famous last words, isn't it? That will come back to haunt me. But we think primary care and those it serves would benefit from a better patient-facing digital offer. I think when you make that statement to anybody, if you don't get too wrapped up in what better means, I think everybody gets it that would be a good thing. So our aim is to establish what that might look like, and then I think the interesting thing will be to work out how that can be implemented. And we recently met with the current and the new CCIOs for North Cumbria Clinical Commissioning Group, and they see the opportunity in this, and they're very keen to work with us to make this happen. I'm conscious my 10 minutes is running down quickly, so that is me. There we are. My 10 minutes is done. If you'd like any more information or you want to contact me, those are my contact details. It will be great to hear from you. I think what would be fabulous for us, for me personally as well, is to come back at the end of March when we've got these things up and running, and also perhaps share the findings with you. I hope that's been useful.
Tom, that was fascinating. Really interesting to hear about that work that's happening in Cumbria. Can I just check a little bit on the scope of the piece of work you're doing? So you've talked about a patient-facing digital offer. And forgive me, I can't think of any other way to phrase this question. Do you mean website, or is it broader than that?
No, it's a very good point you're making. And if at its most basic, you'd say, yeah, it's a website. But actually, what is it? If you look at the exciting initiatives that the two previous presenters are involved with, what should that patient-facing digital offer from primary care be? Are we talking access to apps library? Are we talking access to peer-to-peer networks? Are we talking, for example, access to GP services on demand? Are we talking a bit of artificial intelligence? Are we talking about the social media offer? Are we talking about how practices engage effectively with their patients? So I think that there's a lot to go at here, but I think you're absolutely right to identify that the bulk of that could be encapsulated by saying, how do you get a decent looking GP practice website together, and what does that look like?
Fab. And I'm sure for the people who are on this call and the people who download it afterwards, I think that is a really critical question that a lot of practices are grappling with. So are you happy for people to reach out to you if they have got some good ideas or some suggestions or want to know a bit more? Please
do.
Brilliant.
I think for me, that's, and again, thanks to you guys for making this happen, because I think that power of networking, I think when you're sat up here in Cumbria, and it's quite easy to feel a bit isolated from, the things that are going on in the rest of the Northwest, etc. These are great opportunities to network. So please do make contact.
More than welcome. A great offer there from Tom, I think. So looking at the chat box, we don't have any questions popping up, but I'm sure people will be reflecting on what they've heard, and I'm sure we'll reach out to our speakers for more information. Charlotte, I don't think we've got any hands up. Is that right?
No hands raised at the moment.
Great. Well, thank you everyone for dialing in today. We'll call that a day. Looking forward to hearing you on our next big innovation conversation.